Thank you very much for this kind invitation, and I'm sorry not to be there in Verona with you. So I'm Dr. Lori Margolies from the Mount Sinai Health System, and I'm a breast imager. And I'm going to discuss in the next few minutes the bonus findings on chest CT that involve the breast. So my request for you is to help us find breast cancer as early as possible. And why is that? It decreases morbidity and mortality the earlier we find it. There's less need for mastectomy, less needs for full axillary dissections, and less need for chemotherapy. Unfortunately, the following scenario is far too common when we don't systematically look at the breasts on chest CT. This is the tale of missed opportunity on multiple chest CT exams. This patient did not have a screening mammogram despite a family history of breast cancer and a personal history of colon cancer until she was in her 60s. Here's this cancer on chest CT. It looks like a mass. It has a convex contour. It was also missed 6 months earlier. And 12 months earlier, it was also missed. It was also missed on a PET. So then she had her first mammograms 2 years after this invasive ductal cancer could have been seen on chest CT. Here it is on the mammogram, blown up on the mammogram, and here it is on the ultrasound. Its margins are irregular. It's an invasive ductal cancer. Here's another missed opportunity with a faster growing cancer. This patient also did not have a mammogram. And here you can see the obvious mass surrounded by fat with irregular margins. Unfortunately, 2 years later, it's a large, palpable mass, and her treatment is affected. Her mortality is affected. People may be having chest CTs, but not having mammography. Screening mammography guidelines vary greatly. Some, like the American College of Radiology and the Society of Breast Imaging, suggest yearly mammography beginning at age 40. Others, like the United States Preventive Services Task Force, every other year. Italy, where we are, every other year. And the age to start varies between 40 and 50. Incidental breast findings are common on chest CT. This study found 27 patients with 31 findings out of 35,000 chest CT exams. A relatively low number probably reflects that they weren't looking for them prospectively. But 23 out of those 31 findings were malignant. Mammography has blind spots. It's far from perfect, but CT can maybe see the entire breast. Now, what are some of these blind spots? Behind pacemakers or other devices, the far posterior aspect of the breast, the far medial and far lateral aspects of the breast. Sometimes the edges are not included on a mammogram, and even with screening ultrasound, the edges can be missed. So maybe CT is better than mammography for medial lesions such as this. Here's this patient's prior mammogram. You don't see that. Not here. We know that it's going to be here. Here it is. After the CAT scan, we went back and worked very hard to find it on this one image. Here's a different case, very similar story. Notice that these are all posterior medial lesions that I'm showing. Let me switch to another question. Should women wear bras for chest CT? Wearing a bra increases the amount of breast tissue that's in the area that gets the lowest dose. Here you can see an example from this 2014 paper without a bra and with a bra. You can see how much nicer you see the breast tissue, and you can imagine that a person who had part of their breast cut off on a CT scan might have a lot more of their breast included if they were wearing their bra. How else can chest CT help? Breast density. Those with breasts that are dense benefit from supplemental screening. Both European and United States guidelines have recently been updated to recommend MRI as the supplemental method, with ultrasound or others used if MRI is not possible. So here we've shown that there's a great correlation between mammography and CT when determining breast density. Here's a fatty breast. Here are some scattered fibroglandular elements. Here's a woman with heterogeneously dense parenchyma where cancers can be obscured. Here's somebody with extremely dense parenchyma, and not only is this patient at elevated risk, but cancers can be obscured. But let's not forget the men. Please mention gynecomastia if it's present. Why? If we know that a man has gynecomastia and later presents with pain or a lump in the retroareolar area, we can possibly avoid mammography and ultrasound workup. We see this gynecomastia, it's bilateral and relatively symmetric. And let me just close by presenting a teaser. Breast arterial calcification. Those of you who know me know that this is my favorite topic. So what's new in 2023? There's new data emerging with 10-year follow-up of women who have breast arterial calcification, showing a significant correlation with mortality, a significant correlation with myocardial infarction, as well as a significant correlation with stroke. Reporting guidelines are active in Canada. Others will likely follow, and we can save more lives that way as well. I want to thank you for your attention and all that you do, for all the screening and care that you do. I hope to see you in person next year. If you have any questions, I'll be happy to answer them via email, and here's my email address. And thank you again, and I hope you enjoy Verona.